complications of GI diseases. So one of the first is abdominal pain. So we'll try to keep this short. So this is one of the most common complaints you get in the ER, abdominal pain. So a 52-year-old patient noted crampy hypogastric pain for the past 2 months with associated constipation and weight loss. So what could be the etiology for this disease? So crampy hypogastric pain, 52-year-old patient for the past 2 months with constipation and weight loss. What could be the possible etiology for this one? Anyone? May mga class numbers ba kayo? Hello?
Yes po, Doc.
Sige, number, I can't see the participants. Number 52. Who's number 52?
Hindi po, Doc.
Okay. So so I'll just go by numbers. I can't see the participants. So yun, a 52-year-old patient noted crampy hypogastric pain for the past 2 months with constipation and weight loss. What can you think of? What are you thinking? What could be causing all this? So 52-year-old patient, crampy hypogastric pain, past 2 months with constipation and weight loss. What are your thoughts, number 52? Or anyone na lang? Hello? Hello?
CA, Doc?
Ano na CA?
Colon, maybe?
So colon cancer. So so it's election time. So who among the following could have experienced similar symptoms? So based on their cause of death.
Cory.
So Cory Aquino. So what did who can do you know who the rightmost person is to the right of Cory? And anong cause of death niya?
Plane crash.
Plane crash, si Magsaysay. Tapos si Marcos Sr. who can anong cause of death niya or anong mga complications? Ano? Sa lupus. So mga complications of lupus. Okay, so another case for number 25. A 66-year-old hypertensive male complains of aching epigastric pain for 6 weeks with weight loss and jaundice. So aching epigastric pain for 6 weeks with weight loss and jaundice in a 66-year-old hypertensive male. Number 25, what are your thoughts?
Liver problems.
Anong liver problem?
Cirrhosis.
So will cirrhosis cause aching epigastric pain for 6 weeks? It can cause weight loss and jaundice, pero itong aching epigastric pain. Another guess? Unless there's something else in the liver on top of the cirrhosis. Any other thoughts? Hello?
Hepatitis, Doc.
Pwede man kung... So, you're thinking of acute viral hepatitis. Tama?
Doc.
Usually acute viral hepatitis, not as long as 6 weeks siguro. Pero pwede man, mas medyo prolonged siya, mga 3 to 4 weeks. Pwede man. So abdominal pain, correctly interpreting acute abdominal pain. So this is something that you will see in the ER, in your clinic. Your relatives will call you for this. It can be quite challenging because there can be many causes, and sometimes the most catastrophic events may be forecast by the subtlest of symptoms and signs. So we must, as with all conditions in medicine, we should be able to determine which ones are urgent and which ones can wait. So a detailed history and physical exam are very, very important. So anyone can just chime in. So what are the key components in a patient's history? What should we, when somebody calls you, "Uy, I have pain in the abdomen," well, what should you ask? So anyone lang, you guys, what should be the key components in the patient's history? So if I call you, "Uy, I'm having so much abdominal pain right now," what's your first question?
Location.
A location. So hypogastric, epigastric, right upper quadrant, left upper quadrant. So location. What else?
Onset po, Doc.
Onset. So when did it start? Don't settle with matagal na or yan na lang. Dapat 5 minutes ago, 2 minutes ago, before Yolanda, after Yolanda, something like that. So onset, and then what else?
Duration.
Quality pain.
So duration. Oo. So for a long time na. Okay. Ano pa ba?
Quality of pain.
Quality of pain. So in our region, there are many languages used. So you can get patients from Southern Leyte, from Northern Samar. So you should acquaint yourself with the terms that they use. Or if you're not familiar, you ask them to describe it because they can use other terms. So is it aching, stabbing? Does it feel like something is crushing you? Is it burning? So quality of pain. What else can you ask?
Associating factor.
Associated factors, so relieving factors and aggravating factors. So those are the things that you ask. So time, nausea, anorexia, diarrhea, constipation, weight loss. Menstrual history is very is very important, especially for reproductive age patients in the reproductive age, because sometimes we forget na pwede palang ectopic ito, and then so that's happened in many hospitals na matitriage to IM, and then it's an ectopic pregnancy ngayon. So we have to do our menstrual history. So this is a quick guide. PQRST: precipitating, quality, relieving factor, severity, and timing. And then it's important also to determine the age and also the sex of the patient, because there are some things that happen in males more often than in females, and some things that can happen only in females and not in males. Parang ganun. So most common causes are acute appendicitis, and then there's also non-specific abdominal pain, pain of urologic origin, intestinal obstruction. So those are the common causes. Pero number one actually is non-specific abdominal pain. So in appendicitis, so maybe some of you have gotten appendicitis or have had siblings or relatives with appendicitis. So it usually starts in the epigastrum, and then it will relocate to the right lower quadrant where our appendix is. So it's one of the most common causes. Most patients who present with acute abdominal pain will have a self-limited disease process. However, it is important to remember that pain severity does not necessarily correlate with the severity of the underlying condition. So we have patients who get admitted for gastritis lang or itong hyperacidity, but they feel like the world will end, mga sugad. Pero when you do an endoscopy, it's just mga gas-gas lang sa tiyan, but it can cause a lot of discomfort and a lot of pain. And I'm sure some of you have experienced severe na itong dyspepsia or gastritis. Any patient with abdominal pain of recent onset requires early and thorough evaluation for an accurate diagnosis, because it would be best to catch pathologies early so that we can intervene early and prevent catastrophes. Some important causes of abdominal pain. So pain from the abdomen. We have parietal peritoneal inflammation, so that you're familiar with the parietal peritoneum, and there can be bacterial contamination. So if the appendix bursts or some other part of the GI tract bursts, then all the gastric, the intestinal juices will spill into the peritoneum. So that will cause a lot of pain, chemical irritation. So yun, perforated ulcer, or you can have pancreatitis, or sa girls, Mittel's Merch, obstruction of the large or small intestine, of the biliary tree, ureter, and then ito, mga toxic vascular disturbances like an embolism or a thrombosis, or sickle cell anemia. There can also be traction of the mesentery, and typhoid fever can cause right lower quadrant pain. But sometimes pain from the abdomen can be coming from somewhere else. So we have patients who get triaged to GI pero acute MI ngayon sila, because the pain of myocardial infarction can radiate to or be referred to the abdomen, pwedeng CHF, pwedeng pneumonia. So we've had patients na maoperahan for appendicitis, but the surgeon will go back to you and say that they have negative findings and it was just pneumonia ngayon. So there are some strategies that will help us determine which is which, so that we'll avoid needless surgeries. And metabolic causes, diabetes, it can cause diabetic emergencies that can cause abdominal pain, uremia. So when you have chronic kidney disease na end stage na talaga, you can get uremia, or even AKI, acute kidney injury, can cause uremia, and that can cause also epigastric pain. Other causes can be neurologic or psychiatric, like herpes zoster. So if you have had your lolas or mothers or fathers na nagka-herpes zoster, it's lancinating pain that can occur in any dermatome. So yun, toxic causes, lead poisoning, snake bites, if you've had relatives na bitten by snake, so masakit, pwedeng masakit din. And then, so this is a diagram showing what you should think of when the patient comes to you with, for example, number one, epigastric pain can be from your gallbladder, can be from your liver, can be from your stomach, or yun, after the stomach comes the duodenum. So those are the things that you should think. Number two, so if periumbilical naman, so if your patient comes in with periumbilical pain, you should think of the small intestine, and so yun, yung small intestine or the right side of the colon. Pag hypogastric naman, you can think of the kidneys, the urinary bladder, the uterus, ovaries, and the left side of the colon. So number 42, you have a patient na 57-year-old female with aching pain in the left lower quadrant for 2 weeks. So yung number na sinabi ko, aching pain in the left lower quadrant for 2 weeks in a 57-year-old female. What did I say? Number 42? Number 42. Andyan number 42?
Yes po, Doc.
So, what are your thoughts with this case? So you have a patient, a 57 female, aching pain in the left lower quadrant for 2 weeks. So remember the diagram, kung left lower quadrant, pero tas female pa siya. So what can you think of? So aching pain na medyo maiha-iha, mga 2 weeks na, 57 female. So hindi na siya reproductive age, in fairness.
Diverticulitis po.
So pwedeng diverticulitis. So your patients here, so your patients will come to you, and you should look at the onset, location, character, radiation, intensity. So for example, you have a ruptured aortic aneurysm. So this is one of the emergencies talaga. So ruptured triple A, it's sudden, it there's pain in the abdomen radiating to the back and flank. It's diffuse, it's tearing, and it's as you can see in the intensity, it's very, very, very severe. So kung ruptured ectopic pregnancy, it's also sudden. So somebody with ruptured ectopic pregnancy will not wait for 2 weeks before they can go to you. So it's very sudden, it's also severe, and then it's in the either lower quadrant, pwedeng right or left, the pelvis, it's localized and sharp. So you try to elicit from the patient anong klaseng pain talaga. Because sometimes they'll just say, masakit, maulul. So you really try to give them all the options and mag multiple choice ka mo so that they can help you help them. Types of abdominal pain, you have parietal peritoneal inflammation. It's steady and aching in character and is located directly over the inflamed area. Its exact reference being possible because it is transmitted by somatic nerves supplying the parietal peritoneum. And its intensity of pain is dependent on how much material is spilled into the peritoneum and at what given time. So somebody with parietal peritoneal inflammation, so this happens, as I said, kung may ruptured viscous. So if, for example, nag-rupture na an iya appendix, the patient will just lie very still, quietly in bed, preferring to avoid motion because any motion can stimulate the pain. So in contrast to the patient with colic, if you yourself have had gallstones or your parents have had gallstones, parang the patient will try to look for a position which can provide comfort. So yun, pag may parietal peritoneum inflammation, palpation or even movement such as coughing or sneezing will elicit this pain. So that's why, so yung naka-underline yun. So if what is being taught is to elicit in rebound tenderness, to indicate parietal peritoneal inflammation by di ba, you palpate and then you let it go, you let go of the abdomen, so that will create a lot of pain. So what Harrison says is that you can ask them to cough or sneeze, and then if may pain elicited by that, then you know that there's parietal peritoneal inflammation. And then intestinal obstruction. So it classically elicits intermittent or colicky abdominal pain that is not well localized as the pain of parietal peritoneal irritation. Absence of cramping discomfort should not be misleading because the distension of a hollow viscous may also produce steady pain with only rare bursts of pain. So as you can see with the patient, this is a male patient with a really large abdomen. You can actually outline the bowels na. So that's if you see patients who complain, usually the history is constipation and then distension and abdominal pain and vomiting. You will see patients with really large abdomens. Small bowel obstruction is poorly localized, intermittent, periumbilical, or supraumbilical. So as the intestine progressively dilates and loses muscular tone, the colicky nature of the pain may diminish. And colonic obstruction presents with colicky pain that is of lesser intensity, is commonly located in the infraumbilical area, and may often radiate to the lumbar region. So number 35, what are the risk factors for intestinal obstruction? Dahil number 35.
Yes po, Doc.
What are the risk factors? So name a few risk factors for IO or intestinal obstruction. So it's important when you look at the patient, you look at the whole picture. So if you have a patient na 15 years old, na walang certain risk factors, maybe you wouldn't think of IO, mga ganon. So what are some of the risk factors for IO? Or anyone na lang, anyone.
Tumors, doc, or
Hernias.
So pwedeng ang hernia, so a hernia might strangulate and cause IO. Ano pa ba?
swallowing foreign body, doc.
Ay, sorry. So I heard tumor. So may history of tumor or may symptoms na nagpo-point to a tumor. Pwede, or if you can palpate a tumor, yes, that's one of the risk factors. Ano pa bang mga risk factors for intestinal obstruction that should be part of your past medical history?
Swallowing foreign body po, doc.
So pwedeng So swallowing foreign body, yes. So kung may history siya na itong mga paika na nagsaswallow ng mga hair or something, or mga kung ano-ano, or may nag-insert ng foreign body into the anus, so that can also happen. Parasitism, so ascaris is very known for creating intestinal obstruction and also biliary obstruction. Oo, mga sugad. And then another one is history of previous surgery. So you should always ask that. So even if CS lang or appendectomy, you should ask your patients, because that can already lead to one of the most common causes, which is post-operative adhesions. So those are the things that we ask. And then sudden distension of the biliary tree produces a steady rather than a colicky type of pain. And then acute distension of the gallbladder, so which can be caused by maybe a stone or a stricture, causes pain in the right upper quadrant, radiating to the right posterior region of the thorax to the tip of the right scapula. But it is also not uncommonly found near the midline. So sometimes patients, it's not always the right upper quadrant ang pain, but sometimes it's in the epigastrum. And then distension of the common bile duct often causes epigastric pain that may radiate to the upper lumbar region. And then you can only sometimes see the subscapular pain. So this is the sudden obstruction will cause yun steady pain, and then persistent obstruction, as in acute cholecystitis, this may cause the patient to just lie motionless and they will avoid any movement. Gradual dilatation of the biliary tree. So if you have a carcinoma, so cancer doesn't happen overnight, so it grows bit by bit every day. It may cause no pain or only a mild aching sensation in the epigastrum or right upper quadrant for some time. So yun, you also have to ask about yun, when it started, kung mild lang or very severe. And when it comes to carcinoma, it always helps to ask about weight loss. The pain of distension of the pancreatic duct is similar to that described of the common bile duct, but in addition, it's very frequently accentuated by recumbency and relieved by the upright position. Urinary bladder pain. So some authors have said that this is the worst pain, even worse than childbirth. Obstruction of the urinary bladder causes a dull, low-intensity pain in the suprapubic region. But if you have uretero-junction obstruction, this can cause pain in the costovertebral angle. Obstruction of the remainder of the ureter can cause flank pain that often extends into the same side of the abdomen. In contrast, acute obstruction of the intravesical portion of the ureter is characterized by very severe suprapubic and flank pain that radiates to the penis, scrotum, or inner aspect of the thigh. So for kidney stones, you always ask about radiation into the thigh, into the hypogastrum, to help you with your location. And then vascular pain, there's a frequent misconception that pain due to an intra-abdominal vascular disturbance is sudden and catastrophic in nature, but sometimes an embolism or thrombosis of the superior mesenteric artery or impending rupture of a triple A it can certainly be associated with diffuse severe sudden pain. But occlusion of the SMA only has mild, continuous, and cramping diffuse pain for around 2 to 3 days before vascular collapse. So indeed, the absence of tenderness and rigidity in the presence of continuous diffuse pain in a patient likely to have vascular disease is quite characteristic of occlusion of the superior mesenteric artery. Abdominal pain with radiation to the sacral region, flank, or genitalia should always make you think of ruptured triple A. And kung abdominal wall pain, it's usually constant and aching. Prolonged standing, movement can cause discomfort. So referred pain. So this is one of the things that we should really watch out for because sometimes it can mapaglin lang talaga ang abdominal pain. The possibility of intrathoracic disease must be considered in every patient with abdominal pain, especially if the pain is in the upper abdomen. Systematic questioning and examination directed to detecting MI or pulmonary infarction, pneumonia, pericarditis, or esophageal disease will often provide sufficient clues to establish the proper diagnosis. So if you have right upper quadrant pain and supraclavicular pain, what do you usually think? Na-mention ko na ito actually. So right upper quadrant pain and supraclavicular pain. Supraclavicular pain, not subscapular pain. So you have a patient with right upper quadrant pain and supraclavicular pain. What could be the possible diagnosis? Anyone?
Ectopic, Doc.
Ectopic. So let's see. Ito siya. So if you have pneumonia, so pneumonia, especially in the elderly or pulmonary infarction, you can have diaphragmatic pleuritis. So our lungs are closely associated to our diaphragm. So pwedeng ma-irritate ang diaphragm causing right upper quadrant pain. So, and this can radiate. So you ask kung if you have a patient na coming with right upper quadrant pain, tapos may cough pala siya. And then you ask, is there pain anywhere else? Does it radiate to another area? Then he says na it's also present, or it also radiates to the supraclavicular area. You can investigate, or you should investigate for pneumonia. So the ultimate decision as to the origin of abdominal pain may require deliberate and planned observation over a period of several hours. This shows where pain is referred. So itong blue na it shows na kung ito siya sa may right shoulder na pain, can be referred pain from the liver, gallbladder, duodenum up to the scapular area or diaphragm. Stomach can be referred to the upper intestine, itong green. Tapos, ano pa ba? Yun yung mga referred pain that you should be aware of. So, thoracic referred pain is often accompanied by splinting of the involved hemithorax with respiratory lag and decrease in excursion more marked than that seen in the presence of intra-abdominal disease. Also, you need to ask also, and on your examination, you ask the patient to inspire, to breathe in, breathe out while you're pressing on the area that's tender. And then you ask him, if mag-breathe in ka, if you inspire, is there less pain? So if he says na the pain diminishes during inspiratory phase of respiration, then it might be from a thoracic source and not an abdominal source. And then palpation of the referred pain in the abdomen actually seems to relieve it. So those are the clues na pneumonia lang ngayon ito. Thoracic disease and abdominal disease frequently coexist and may be difficult or impossible to differentiate, but we will always need to try, and we should be aware of where these thoracic causes radiate. Metabolic origin. So metabolic diseases, systemic diseases can cause abdominal pain, and then like yung C1 esterase deficiency is associated with angioneurotic edema and severe abdominal pain. Whenever the cause of the abdominal pain is obscure, a metabolic origin should always be considered. And yun, the pain of ito mga less common causes, pain of porphyria and of lead colic is usually difficult to distinguish from that of intestinal obstruction because severe hyperperistalsis is a prominent feature for both. The pain of uremia or diabetes is non-specific, and it can frequently shift in location and intensity. So you'll be more acquainted with diabetic acidosis as you move through the year, and it can be precipitated by acute appendicitis or intestinal obstruction. So prompt resolution of the abdominal pain does not result from correction of metabolic abnormalities if there is an underlying organic problem. And then immunosuppressed patients. So when you deal with immunosuppressed patients, so those who are undergoing organ transplantation, those with diabetes, mga lupus, mga autoimmune diseases, those with AIDS, it opens the door to even more pathologies. So normal physiologic responses may be absent or masked. And also unusual infections can cause pain. You will be dealing with CMV, mycobacteria, protozoa, and fungi, which we immunocompetent people would have been able to fend off, pero sila, they're exposed to all this. And so you should also ask about the past medical history, kung may history of transplantation and all those things that I mentioned. And regarding AIDS, you should always ask about sexual history also, and test whenever necessary. Test for HIV whenever necessary. So neurogenic pain. So the classic example is herpes zoster with a lancinating pain, and usually it's not associated with food intake, abdominal distension, or changes in respiration. And it's made worse by movement of the spine and is usually confined to a few dermatomes. And yun. I'd like to highlight this lang. So IBS is very common. I'm sure some of you have had irritable bowel syndrome, which is a functional GI disorder characterized by abdominal pain and altered bowel habits. And diagnosis is made on the basis of clinical criteria and after exclusion of other structural abnormalities. And the episodes of abdominal pain are often brought about by stress. So a lot of patients during exam time have constipation or diarrhea or pain, and the pain varies considerably in type and location. So this is actually neurogenic pain because there's no real organic cause for the pain. Wala namang bukol dito or wala namang ulcers, but the bowel remains very, very irritable. Approach to the patient. So we rule out urgent situations. Few abdominal conditions require such urgent operative intervention that an orderly approach need be abandoned, no matter how ill the patient. So as much as possible, dapat diri kita mataranta. We should be able to do a thorough history PE to help the patient. Only patients with exsanguinating intra-abdominal hemorrhage, like a ruptured aneurysm, must be rushed to the OR immediately. Otherwise, we get to have the luxury of time to do our thorough investigation. There are no contraindications to operation when massive intra-abdominal hemorrhage is present. Fortunately, rare naman ito. So this is taken from another book, Schlesinger. So when you have a patient coming with acute abdominal pain, with prostration, hemodynamically unstable, you resuscitate. So you insert your IV cannula and you give your fluids. You refer to surgery. Consider a fast examination, which is a focus ultrasound, and you consider laparotomy. And the most likely diagnosis for this case are perforated viscous, severe panc, ruptured spleen, or hemoperitoneal, or ruptured AAA. Pero if not naman, walang prostration, walang hemodynamic, if the patient has stable vital signs, then you think of other things. If the patient has right lower quadrant pain na gradual onset, or right lower quadrant tenderness na localized with rebound tenderness, you do a CT ng appendix. And in female patients, consider an ultrasound or CT to see if may tubo-ovarian abscesses, ovarian torsion, ectopic preg. And then if gradual onset naman ng right upper quadrant pain, then you do an ultrasound. It's one of the best screening tools. And then if there's nausea, vomiting, constipation, obstipation, abdominal distension, and yun, prior surgery, then you do an upright film. Sudden onset naman, diffuse pain, involuntary guarding, rebound tenderness, peritonitis, then a contrast CT would help. So we're almost done naman. You do a detailed history, ask about the location, and determine the location with your physical exam. And then chronology or sequence of events is very important. And analgesia as necessary. So some will advise you to just lay off on the tramadol, on the pain relievers to see how the pain progresses. Pero if you have been in pain, if you have been a patient in pain, you will be you will know the suffering that a patient goes through kung walang analgesics. So just give the analgesics and do your thorough investigation. Menstrual history, as mentioned, is very, very important. Okay. And then, yan. So right upper quadrant, these are the things you think of. Epigastric, nasa Harrison's naman to, spleen. Yan, left upper quadrant, right lower quadrant, periumbilical, and left lower quadrant. So try to familiarize with the things so that you can think of your differentials depending on the location. And then on physical exam, simple critical inspection of the patient. So just looking at the patient, is the patient moving around? Is the patient sitting up? Because the patient will choose always the position that provides relief. So just looking at the patient na makiwa-hiya or adto lang parang stiff as a board, breathing so fast. So these will provide you clues. So be very gentle and thorough. So when you palpate, be gentle because it can be very painful for the patient. So when you elicit rebound tenderness, you can percuss or ask the patient to cough. Nakamask naman ang mga patients yan. And a palpable gallbladder will be missed if palpation is too aggressive. So just be gentle and try to distract the patient because sometimes the patients can be very conscious that you're palpating their abdomen. So you can talk to the patient while you're palpating, and you can see in their you can ask them if it's painful, or if may guarding, and if you're suspecting na the patient if you're suspecting something else, pwede mo i-distract ang patient with history taking, and then you can see if magigrimace ang patient or not. And then abdominal signs may be virtually or totally absent in cases with pelvic peritonitis. So a careful pelvic and rectal exam is mandatory in every patient with abdominal pain. That's what Harrison says. And tenderness on pelvic or rectal examination in the absence of abdominal signs can be caused by operative indications such as perforated appendicitis, diverticulitis, twisted ovarian cyst, and many others. Also, listen to your bowel sounds. So listen to every quadrant, and you listen if it's normoactive, hypoactive, absent, or hyperactive. CBC can help you determine if there's an infectious cause. A urinalysis will also help to determine if there's hematuria, or if there's UTI. Amylase lipase for your panc. Electrolytes will help you, especially for metabolic causes. Sige, number 62. What can you see in the X-ray? Number 62. Almost done naman kita. Number 62? Dahil number 62? Hello? Number 62? Hello, can you hear me? Hello? Number 62? Or number 60 na lang? Number 60, are you there?
Yes, Doc, I'm here.
What can you say about the X-ray?
I don't have an idea po, Doc.
Sige, so let's ask help from your classmates. So who can comment on the X-ray?
Small intestinal obstruction, doc, with air fluid level.
So there are air fluid levels. So this is an abdominal X-ray. As you can see, may nakalagay erect. So it's an upright abdominal film. So it's important to determine if it's upright or supine na film. And then you can see black and white images lang talaga kita for X-rays. But here you can see that there's like a step ladder pattern. So there are different levels ng, so black on X-ray, black indicates air. So there's air, and then the white na may mga meniscus sign are the fluid. So may differing na air fluid levels. This is in the small and large intestine actually. And then this happens because in a normal bowel dapat nagfo-flow lang ang fluid and the feces dapat ma-excrete nato. So in patients with intestinal obstruction may bara, so they cannot flow, and the bowels can initially be hyperactive trying to overcome the obstruction. That's why there are different air fluid levels, and the bowels are actually dilated. So dapat it should be smaller in caliber in a normal person. This one, anyone would like to comment? So nakalagay apple core appearance of the colon. What type of study is this?
Barium enema, doc.
Barium enema. Tapos usually, anong ibig sabihin ng apple core?
Cancer, doc.
Ano?
Cancer.
Cancer.
Cancer. So it can be a tumor. So pwedeng not necessarily cancer, pero a tumor. So it can be a growth. So in barium enema, like in barium swallow, so we look at how the contrast media flows through the colon. So dapat dire-diretso unta. Here you can find that there is it really looks like an apple core because there is a growth that should not be there. So other procedures, CT scan is helpful in a lot of cases. And then here, the first picture shows a gallbladder with a stone. And yun, a HIDA scan will help you when you're dealing with cholecystitis. So sometimes even in the best circumstances, with all the available aids and with the greatest of clinical skill, a definitive diagnosis cannot be established. Nevertheless, even in the absence of a clear anatomic diagnosis, it may be abundantly clear to an experienced and thoughtful physician and surgeon that operation is indicated on clinical grounds alone. So sometimes, based on clinical grounds and a few labs, we can determine na kailangan talaga operahan. Should the decision be questionable, watchful waiting and repeated questioning and additional laboratories examination will help enlighten you. So yun lang. Ay,